Welcome to the Honors Colloquium. We're thrilled that you're here tonight. I know we're going to have a very exciting evening. Two on the side and the back, and then two here in the front. And there's a ladies' room on your right downstairs, and a men's room on your right downstairs, on the left, and then there's a unisex bathroom out in the lobby. I'd like to thank tonight Cox Communication, who is a university sponsor of the Colloquium, and I'd like to welcome two members of the Cox staff that are here today. Mark Scott is the Vice President of Cox Business, and Ross Nelson is Director of Sales. And thank you for attending and for your support of the Honors Colloquium. At this time, it is my honor to introduce Dr. Dale Joseph, who is the former Dean of the College of Nursing, and she will be introducing First Lady Stephanie Chafee.
Good evening. I have to say it's a real honor to be here. We have planned this day a long time ago actually now. It was before I made the decision, in fact, to retire. But it gives me great pleasure to be here and to introduce Stephanie Chafee. Before I do an introduction, I just have to tell you that I was fortunate enough to go to her class tonight that she taught to the honors students. And I think the students who are there should give her a great hand because it was a wonderful class and it was delightful for me to be back at school again and really listening to what students have to say. So we want to thank you for that, Stephanie. I'd like to tell you a little bit about Stephanie. She began her college career at Bowdoin, and then she transferred to Boston University because she decided that she wanted to be a nurse. She worked in nursing for about a year, and she decided that she wanted to go back to college and that she really needed to know something about the business end of things. So she got an MBA at the University of Connecticut. More recently in her career, she earned an honorary doctorate in humane letters from the University of Rhode Island. And I have to say that's really important to me because I've known Stephanie for years as a nurse, and I was always a little bit disappointed that she wasn't a URI graduate. So for her to have the highest honor of the doctorate of humane letters, it makes me extremely happy. She is one of the first nurses in Rhode Island to work with HIV/AIDS patients. And after that experience, she developed the Rhode Island Free Clinic, and that was in the late 1990s, the early 2000s. She believed in a whole system of volunteerism and that we need to help the working poor, people that do not help insurance, and we need to do it on a volunteer basis. And I remember having a discussion with her where she was convinced that we needed to do it. She was convinced that I needed to help her. And I was sure that she was crazy, but I didn't want to say no to her, and I'm still volunteering there, and I have to say I've loved every minute of it. And it's a very, very important place in Rhode Island's community and for health care in Rhode Island. She is featured as one of the 25 models of promise in Shirley Sagawa's The American Way to Change. She was co-founder of Women's Ending Hunger, and she's a community health advocate for all Rhode Islanders, particularly the underserved. She has served on many boards throughout her career: the Miriam Hospital, Rhode Island Hospital, the Rhode Island Foundation, the Rhode Island Zoological Society, and presently she's on the South County Hospital Board. It is with pride that she brings her knowledge of health care and social justice to the table as Rhode Island's First Lady. I think what you're going to find, her real strength is that she's passionate. She is passionate about health care, and she is passionate about helping people that really need our help. So it is with great pleasure that I introduce Stephanie Chafee to you.
Thank you. Well, I want to say thank you so much to Dale. She has been an inspiration to me, a mentor, and yes, we were kind of crazy back then, but look at what we accomplished. Before I begin tonight, I want to take a moment to honor URI's recipients this year for Shape Up Rhode Island. Shape Up Rhode Island is a wonderful organization. It was started by at the time, a medical student, Rajiv Kumar, at the Brown University Medical School, who felt that there was a way to help transform people's health by using social media platforms. And those of us who were in class this afternoon, we had a discussion about how does technology change this generation. And it changes this generation in a multitude of ways, some of which are good and some of which are not so good. But this is a way in which it's really extraordinarily wonderful. So Shape Up is about just that, making us healthy human beings here in the state of Rhode Island. And there are several different categories that one can compete in. And so I'd like to first ask up Jennifer Castro's team. They average 13,883 steps every single day. And I can tell you, that's a lot of steps. I have done Shape Up and ran that little pedometer, and it is about 10,000 steps your feet start to hurt. So to see them doing 13,883 steps, I want to applaud them. Are they here? No? But we'll applaud them anyway. Exercise, 135 minutes. I have to say I don't do a very good job on exercise, but I'm hopeful to do more. And we'll recognize Emily Tomlinson's team, the Healthy Rams. So thank you them. Are they here? Anybody from their team here? No? Okay. And we'll recognize again Fruits and Veggies, 7 servings a day. I don't know how they did it unless all they did was eat lettuce. And that would be Austin Hayes' teams, the Monads. And then URI did, are they here? Jennifer's team, yay! So come on forward. Maybe you just share a moment how it was to do almost 14,000 steps a day.
It was a lot of walking. Actually, most of my team was RAs, and so I think we got a lot of our steps from our rounds when we're on call at night, which is kind of convenient. Also, a bunch of us either are distance runners, so that helped, or we are in classes that are literally across campus from each other, so we'd be walking back and forth, but it was nice.
Great. Thank you so much. I'm really proud of them. As I say, 7 I think is really hard. How many of you think you even get 5? Not too many. How about 3? A little more. 1? It's a very difficult number to achieve, I have to admit. When I did the Shape Up Rhode Island, I did steps and I did my fruits and veggies, and I think I only made my fruits and veggies about 2 times over a 6-week period, so it's hard. URI investigated another very important factor for good health, and that's sleep. And as we know, college students tend to not get 8 contiguous hours of sleep at any one given point in time. And so I want to applaud this team for sleep 8 hours. I think it's extraordinary. And so hats off to Daniel Sandra's team and Emily Thompson's team for their work on 8 hours of sleep. Before I begin tonight, I'd really like to say thank you to President Dooley and his wife for hosting me for dinner. It was lunch, dinner to me, but for dinner tonight, it was a wonderful opportunity to sit and talk with the students and some of the faculty and learn a little bit about what's happening here at URI.
Hi, I'm Danielle.
Yay, Danielle, come and tell us about sleep.
Well, I guess my team is really fortunate to have a lot of later classes in the day, so we usually don't start until about 10 or 11 o'clock every day, so we do manage to get a lot of sleep in, so we're definitely very grateful for that and really place sleep at a high priority in our day, so I guess it showed.
Yeah. And I bet you had good test scores as a result.
We did. We're all doing very well.
The research shows that if you get an adequate night's sleep, actually the test scores do improve, and it's something, of course, we all need to be cognizant of, particularly if you're in a academic setting. I want to say again thank you to President Dooley for having a wonderful dinner, and I know his wife Lynn would love to be here this evening listening to me, but I know she's out supporting a basketball game that's occurring tonight. So I thank all of you for being here to hear what I have to say as opposed to being at that basketball game. I also want to say thank you to my husband. It really is an honor for me to have the governor here this evening to hear what I have to say. It's kind of a funny role reversal because I kind of spend most of my life listening to him give remarks at various places. So it feels a little odd to me to be up here and to have him in the audience. So I would like to begin. Tonight, I am here not only as the wife of the governor, but also, as many of you know, as a registered nurse who has worked with underserved populations my entire professional career. I have worked in Hyden, one of the poorest counties in Kentucky, for the Frontier Nursing Services. And I have worked in Rhode Island for the South County Visiting Nurses. I have also been an HIV/AIDS clinical nurse specialist. In those roles, among many others, such as starting the Rhode Island Free Clinic, I have witnessed heartbreaking and devastating examples of poor health among many different populations. Poor health that could easily have been avoided and prevented if our system of care was not broken and misaligned. So tonight, I would like to focus in on one specific population that presents multiple challenges to us all. The population I will be talking about tonight is women of childbearing age, specifically about our collective interest in ensuring that every child born is a wanted child. So before I begin, I would like to define a couple of terms that I'll be using. The first term is unintended pregnancy. An unintended pregnancy is defined as a pregnancy that was either mistimed or unwanted. If a woman did not want to become pregnant at the time of conception, but did want to become pregnant sometime in the future, that pregnancy is considered mistimed. If a woman did not want to become pregnant at conception or at any time in the future, that pregnancy is considered unwanted. Throughout my career in healthcare, I have observed, as I'm sure many of you have, that the women who are most likely to bring healthy babies into this world and raise them to be healthy children and later to be healthy, happy, productive adults are women who want to be pregnant. Women who have made an active choice to become pregnant and who are educated about pregnancy, prenatal care, and ultimately child rearing. Although my kids I think are okay, but child rearing was a little difficult. I have observed that unwanted or mistimed pregnancies are more likely to have problematic outcomes than those that are planned. And the data reinforces this. According to the Guttmacher Institute, quote, unwanted or mistimed births are associated with such adverse health outcomes as delayed prenatal care, premature births, and negative physical and mental health effects for children, end quote. An overarching goal, then, should be avoiding unwanted pregnancies, ensuring that those that do occur are wanted. This isn't really about sex. It is about social justice. It's about the lives of mothers and their children. It's about giving women and parents the power to plan their lives, to control their futures, and to bring children into this world when they are ready. So how do we achieve this? Well, I'm a realist. I believe that a combination of comprehensive family life education, universal preconception counseling, and greater access to reliable, safe birth control is the most effective way to prevent unplanned, unwanted pregnancies. Did you realize that most unintended pregnancies are due to incorrect or inconsistent use of contraceptives? Education and counseling are key. These are not new concepts to American society. Margaret Sanger, back in 1916, almost 100 years ago, opened the first clinic in the United States that distributed information on contraception and contraceptives. She and many other individuals in the world believed that in order for women to have a more equal footing in society and to lead healthier lives, they needed to be able to determine when to bear children. Sanger, like us today, saw that there is a direct, inverse correlation between one's education level and the likelihood of unplanned pregnancy. The more education you have, the less likely you are to have an unplanned pregnancy. The less education you have, the greater the likelihood of having an unintended pregnancy. In 2008, the national data showed just that. Among women aged 20 to 29, the unintended pregnancy rate per 1,000 was 197 for women with no high school diploma, versus just 65 for women who attended college. This means that we must reach those who are most likely to experience unintended pregnancies before they leave high school. We have a very narrow window to teach many of these young women about reproductive health and how to be proactive in family planning. Our Rhode Island state regulations concerning comprehensive health education supports and promotes this approach. Expanding health education, of course, comes with a cost. And unfortunately, with such an emphasis on standardized tests and academic benchmarks, some of the other valuable programs, indeed, education that could prevent a student from having to drop out due to an unintended pregnancy, have been minimized or crowded out. We want to have our students performing well on standardized tests, but we also must ensure that health education is considered equally important. This education must be realistic. While discussions with our younger students should certainly include an emphasis on abstinence, it cannot be abstinence only. Research from the University of Georgia has indicated a strong correlation between abstinence-only education and an increase in teen pregnancies and birth rates. We should absolutely encourage teens to choose abstinence, but we cannot ignore those who do not make this choice. And we know many of them do not make this choice. The Center for Disease Control and Prevention administers a survey called the Youth Risk Behavior Surveillance Survey. This survey is anonymous and voluntary and is distributed among high school students and middle school students at random. I'd like to share with you some of the results they found from 2011. 14% of middle school students reported that they had had an intimate experience. Yet less than 70% reported that they had any education around HIV and AIDS. 43% of Rhode Island high school students report they have had an intimate experience, and 5 of them had that experience before the age of 13. 5%, sorry. 10% of Rhode Island high school students have been involved with more than 4 people. And 32% of the Rhode Island high school students report having relationships with more than 1 person in just the past 3 months. 20% of Rhode Island high school students reported drinking or using illicit substances the last time they had an intimate relationship. 8.2% of our Rhode Island high school students reported that they had experienced dating violence. The good news, 60% of our students used a condom, 23% of our students used birth control, and 83% of our high school students reported that they had received some education around HIV and AIDS. So it's really clear, an abstinence-only approach will not resonate with the many, many students who are choosing to engage in sexual activity, and it will not help those who are choosing to do so without protection. We need to ensure as a society that both men and women have equal responsibility for their intimate actions. We also know that abstinence-only curricula does not work in preventing unwanted pregnancies. So in addition to education, we must give our young people access to the services they need to avoid unintended pregnancies. This statistic really bothered me. 75% of Rhode Island women who became pregnant before the age of 20 did not want to or plan to. 75%. In Rhode Island, for women, childbirth is the leading cause of dropping out of high school. Nationally, fewer than half of teenage mothers ever graduate from high school, and fewer than 2% earn a college degree before the age of 30. We also know that in Rhode Island, once a teenager has had an unwanted pregnancy, she is far more likely to have another one before the age of 20. And as many as 83% of those teen pregnancies occur in low or poor income families. In addition, there is a strong intergenerational pattern of early childbearing. At least 1/3 of teenage mothers were the children of adolescent mothers themselves. Therefore, in conjunction with education, we must provide access to contraceptives and encourage their correct and consistent use. I know there are many different issues and points of view on this topic, but I view this as a common sense healthcare issue, one that has significant effects on the well-being of the people of our state and nation. Today, in Rhode Island, there are many barriers standing in the way of adolescents and the contraceptives many of them need to avoid unintended pregnancies. For example, access to general medical care is a very important factor in teen pregnancy prevention. And although only 7% of Rhode Island's children under age 18 were uninsured between 2006 and 2008, approximately 40% did not receive a well care visit in the previous year. Additionally, 40% of Rhode Island adolescents do not have a medical home. This, in my mind, is a critical component in avoiding teen pregnancy, And any efforts to address these challenges must include yearly preventative care visits, which include preconception counseling for all adolescents, both boys and girls. And let's be honest, we need to work with our Rhode Island primary care doctors and practices to be sure that anyone who takes care of our adolescents is comfortable talking to our youth about their sexual behavior and family planning issues. That each and every primary care doctor understands preconception counseling and makes sure that it is provided to all our adolescents each and every year. Another major issue is that there is currently no state law regarding consent or confidentiality for youth accesses to contraception. Without clarity in the law, there are no regulations that are either prescriptive or prohibitive of adolescents' access to contraception. Accordingly, some physicians, nurse practitioners, physician assistants may not feel comfortable providing contraception to adolescents without specific legal protection. Some providers have also reported discomfort with discussing sexual health with adolescents and have expressed the need for additional information and training about how do we effectively communicate with young people. Additionally, we know that there is a lack of awareness among primary care providers about the safety of long-acting, reversible contraceptive methods, such as an IUD. Our Department of Health needs to be working with all our primary care practices, our doctors, our nurse practitioners, our physician assistants, our nurses, our social workers, and so on. All of them need to know how to talk about these important issues and feel comfortable talking about all the different methods of contraception that are available today. There are more barriers, too, for our teens. Another barrier is lack of transportation to healthcare settings, which include walkability and bus routes. Many adolescents are hesitant to use healthcare settings within their immediate neighborhood. Why? Well, they're embarrassed, or they're afraid they'll be recognized, and the parents will be called to say, "Did you know your daughter was showing up at Planned Parenthood?" Therefore, we must bring health services to adolescents where they are, as with school-based health programs. In the state of Rhode Island, we have two great programs in the schools. One is Woonsocket High School, and the other is the Met School. Both of these places offer access to contraception within the context of a medical visit. Unfortunately, though, many of our health centers in the state are unable to directly provide contraceptives to adolescents on site, and they must then be referred elsewhere. Bringing access of contraceptives to our students where they are is one of the most important solutions that can help Rhode Island reduce the number of unplanned or unintended pregnancies occurring in our state. Adolescents often feel uneasy, too, talking to healthcare providers about issues regarding sexuality. They need to be motivated and engaged to be self-activated patients who seek out services, and they need helpful and accessible adults, such as teachers, coaches, and mentors, to provide counseling and referrals. Counseling and education about family involvement can also be helpful. For example, how do young people discuss sexual health and family planning with his or her own parents? That was a discussion point in today's class. The importance of comprehensive, Medically accurate family life education within the schools cannot be overstated, but this education should not be limited to the classroom. Peer education can be very, very effective, and counseling and education about resisting sexual coercion or reproductive coercion is extremely important. Youth development programs, such as Youth in Action and Youth Pride, which connect youth with caring adults and provide opportunities for meaningful youth engagement, have been proven to reduce a wide array of risk-taking behaviors. Finally, it's critical that family planning be framed within the context of overall health and wellness. Adolescents should be encouraged to create a reproductive life plan about when and if they want to have children, and thoughtful consideration is given to their goals, their values, their ambition for education, their family life, and their financial stability. Young people also need to be educated about preconception health, about how being healthy and or engaging in risky behaviors will affect any future pregnancy. We've talked a lot tonight about education, and while that is indeed critically important, any honest discussion on pregnancy must acknowledge that, in addition to educational level, there is a strong link between socioeconomic background and unintended pregnancy. According to the Guttmacher Institute, quote, social and economic disadvantage has long been associated with increased risk for unintended pregnancy and continues to be its hallmark, end quote. Earlier this year, Melinda Gates gave a TED Talk, and I encourage all of you to take the time to listen to her TED Talk. And she discussed these issues on a very global scale. She talks about the relative infrequency of family planning in parts of Africa and South Asia. Well, that may seem like a world away, but I see the same disparity on a much smaller scale right here in Rhode Island. At-risk births are much more common in our urban communities. In 2010, I want to share with you that data. At-risk of births, 89.9% in Central Falls, 77.8% in Providence, 75.8% in Woonsocket, and 72.1% in Pawtucket. That compares to 24% in Barrington, Rhode Island. And the rates are similarly placed for teen pregnancy. Central Falls has a rate of 121 per 1,000 against the Rhode Island average of 50. But overall, our core cities, that rate was 72, when the rest of the state was 32. And teen pregnancy rates among blacks, Hispanics, Native American Rhode Islanders were almost twice that of whites. And it goes beyond pregnancy. Rhode Island high school graduation rates are significantly lower in the 6 core cities, with an average of 63% for the core cities to 83% for the remainder of the state. That means our urban minority youth are disproportionately affected by both health and educational disparities. Residents of low-income urban areas are much more likely to lack access to contraceptives. They are also likely to have less disposable income to go into a drugstore and purchase condoms or pay for birth control. They may be unaware of Planned Parenthood or unable to secure transportation to reach a Planned Parent or other location where they might be able to access contraceptives. They may not know about our city and state networks of community health centers. which provide affordable, confidential family planning services. We need to get the word out. We need to get the word out about safe, reliable contraception available in almost every community in the state of Rhode Island. And we need to recognize the connection between poverty and unplanned pregnancy and target low-income minorities in our urban communities for increased family life education, preconception counseling, and access to contraceptives. We need to be proactive. We need to be proactive in reaching all Rhode Island adolescents and youth and make birth control available absolutely free of charge. Helping Rhode Islanders take care and take control of their family planning will have tremendous economic benefits for our state as well. When an unplanned pregnancy does occur, that woman is less likely to go out and reach her potential. Her ability to work is affected during and after her pregnancy. Her child will present an additional economic need for her household. All of this represents a significant drain on her and on our economy, one that easily could have been avoided with greater choice as to when and if pregnancy is the right decision for a given woman. So let's take a look at some of the economic costs. The Rhode Island Pregnancy Risk Assessment Monitoring System data, I know these words are crazy, PRAMS is what it's called, tells us this. In 2010, out of all the births in the state of Rhode Island, 38.6% were unwanted or mistimed. Among Medicaid pregnancies, 55% were unwanted or mistimed. That translates into 2,840 unintended births paid for by Medicaid. Additionally, we know that the children of unplanned pregnancies are more likely to encounter barriers throughout their childhood and adolescence, often ending up in institutions. That presents a great cost to society and our states and exasperates the challenges to us all. Some of you may know the book Freakonomics, written by Stephen Levitt and Stephen Dubner. They point to a number of studies and evidence demonstrating that endowing women with family planning choices has positive effects on society. The authors argue two factors: childhood poverty and single-parent households. They state that these are the strongest predictors that a child will have a criminal future. Growing up in a single-parent home roughly doubles a child's propensity to commit a crime. So does having a teenage mother. Another study has shown that low maternal education is the single most powerful factor leading to criminality. These are powerful indicators that clearly demonstrate the need for health education and easy access to contraceptives. This also underscores the fact that wanted, planned pregnancies produce children who are much more likely to grow up in families in which both parents play an active role. The children of unwanted or unplanned pregnancies who grow up without active, involved parents often perform poorly in school, requiring additional educational resources. They often get involved in crime, requiring the attention and intervention of law enforcement. This means increased costs to the state, costs that particularly in these times of scarce resources are significant. The fewer unplanned pregnancies we have, the smaller the eventual burden on the resources of the state and nation and our society at large. The debate over the rights of women to make their own decisions regarding their health, their bodies, and their future must be protected. This debate has been occurring since Margaret Sanger's time and before. In 1914, Sanger clearly stated and proclaimed that each woman should be, quote, the absolute mistress of her own body, end quote. It was not so long ago that women were prohibited from voting or owning property. We laugh at that ridiculousness now. But have we really progressed all that far? Have we really progressed when women's health and lifestyle choices can still be subject to the approval of others? If a woman chooses to be intimate with a man, then she needs to have the same level of assurance that the man has as to a pregnancy. Back in 1917, when Margaret Sanger went to trial for distributing contraceptive information and contraceptions, the trial judge stated that women did not have, quote, the right to copulate with a feeling of security that there will be no resulting conception, end quote. I am sorry to say that I believe that this sentiment still exists on some levels today in our society. So far tonight, I have talked about preventing unwanted pregnancy, which is critical. But we also need to focus on what we can do once a pregnancy does occur. If a woman does make the choice to continue her pregnancy, access to prenatal care is the first critical step. In 2011, 14% of the state's Title V maternal and child health block grant funds went to programs that support pregnant women. And a key priority of the state is initiating a prenatal home visit program. Why? Because we learned from the PRAMS data that many of our women do not access prenatal care. In fact, between 2006 and 2010, minority women were almost twice as likely as white women to delay in receiving prenatal care, in delivering a low-weight birth rate infant, and in delivering a preterm baby. We also know that African American families continue to have an infant mortality rate that is more than twice that of white families. The March of Dimes is a strong ally in supporting healthy babies. It reports that the average first-year medical cost, including both our inpatient and outpatient medical care, were almost 10 times greater for preterm infants. Preterm infants, on average, cost $32,000 versus a full-term healthy baby, which costs $3,300. Take that forward to 2011, when there were approximately 1,131 premature babies born. They cost us almost $36.5 million versus what it would have cost if they had been healthy for full-term babies of $3,700,000. That's almost a $30 million difference. We have a long way to go. Again, the long-term solutions to so many of the challenges that jeopardize the health and well-being of Rhode Island mothers and children are about increasing access to education and alleviating poverty. When that happens, all of these negative factors that I have been talking about this evening will begin to diminish. There will be fewer unintended pregnancies and fewer parents who are unprepared or lack access to proper pre- and postnatal care. In the meantime, though, we must focus on addressing the issues themselves. Rhode Island must have comprehensive, enhanced health education in our schools that teaches students to protect themselves against diseases, infections, and unplanned pregnancies. We must make birth control readily available, and we must focus our efforts specifically on students from low-income families in our urban communities. Those are the ones who are most likely to experience an unintended pregnancy in their teen years and beyond. When a Rhode Island woman becomes pregnant and decides to continue her pregnancy, every effort must be made to connect her with the proper care and training. Once the baby is born, health professionals must be hands-on in identifying risk factors, tracking health conditions, and ensuring adequate care in the critical early months and years of a child's life. Ultimately, though, let's be honest, it is the parents who are responsible for the well-being of a child. The state should continue to increase those reached by parents' education and family support programs. Educated, trained, engaged parents are the very best way we have to raise happy, healthy, productive children. Now, I know that some of these topics tend to generate controversy, squeamishness, uncomfortableness, but really they shouldn't. This is not about promoting risky or unhealthy activities. Studies have shown repeatedly that access to birth control does not affect one's choice. What this is about is empowering those who are already in an intimate relationship or thinking about it, and to make responsible decisions for their future. Parenthood is a sacred experience, and whenever possible, it should be a proactive choice. We all, and I mean that, we all want to give the very best to our children. But those who have no control over the reproductive process jeopardizes their ability to do just that. What I have talked about this evening will improve health and well-being for mothers and babies and our cities, our state, and our nation. It will strengthen our economy, and we will make our culture a better place to live in. It is to promote social equity for all, and it is just as simple as that. Thank you. So they're going to send me some questions.
As a nurse, what women's health issue is most concerning to you of all the things you've listed? What can we or other healthcare professionals do to address it?
So as a nurse, I think I just spent a long time talking about contraceptions and women's health, and I still believe that we really haven't gone as far as we could as a society. I do believe on many levels we're still back in 1916, where it's very difficult for our young adults to access adequate family planning, medical care, reproductive care. I think this remains a critical healthcare issue going forward.
Next question: how do we best address the how do we best address the extreme disparities in unintended pregnancies in Rhode Island?
The data is pretty clear in Rhode Island, showing us that our urban core cities are where we're seeing the most unintended pregnancies. And in addition to that, the data from the educational side is showing us that we are not doing a very good job of providing health education in our public schools. The sad reality is 100 minutes a week is allocated in our public schools between health education and physical education. And most of the teachers that I have spoken to, so I'm only going to say it's a small sampling and I cannot verify that it is representative of the entire state, but the teachers that I have spoken to tell me that healthcare education is being oftentimes delivered by the physical ed teacher. The phys ed teacher does not feel comfortable discussing this subject matter, and frankly, I don't blame him or her. It's not an easy subject matter to have in a classroom, and you do need training education to learn how to deliver this information to a classroom. And then you're buttressed against the fact that you've only got 100 minutes a week. And you're supposed to get all your phys ed in that 100 minutes, and then the phys ed teacher's supposed to be doing the health education. So I think really we have to go back to the drawing board and put health education as one of the major priorities that we actually start to monitor, we test for, to make sure that students at least are getting the factual information that they need to help them make decisions as they go forward. Right now we're not doing any testing, so we really have no great validation other than the anonymous survey that's done through the CDC.
With the result of the presidential election, what do you hope to see in terms of policy addressing the issues of women's health?
Well, I'm so excited, to be honest, that Obama won. I don't know how much Michelle influences him or how much his girls influence him, but he gets it. He gets that women's health is critically important, and I think we're going to continue to see him push the envelope on many of the issues that I've already raised tonight, and I'm right there supporting him.
How can we co-opt the Rhode Island religious community to work with education and healthcare professionals to protect our young adolescents from unplanned pregnancy?
Okay, can you help me with that one? I'm not sure. I have to be honest, it's something I have struggled with. How do I find the middle ground for people who have different religious beliefs around the conversation of intimacy? All I can keep saying is I have an open door, and I hope all of us have an open door and continue to have ongoing dialogue with all people who have different religions and different cultures to say, how do we solve this? How do we find the comfort zone, the common ground for all of us here in the state of Rhode Island by being mutually respectful of our differences and also acknowledging, though, that we are creating a continual cycle going forward for these young women that I would so much like to see have an opportunity to have everything else that other people have who have not had an unwanted pregnancy during their adolescent years.
If classes were added to high school education about the proper use of contraceptives, how much more would it cost the state to put these classes in effect? And do you have any influence on anyone who would make decisions?
You can talk to him directly. He's right here. Certainly he's heard me. I don't know what the cost is. I can tell you that I've spoken with several people in the Department of Health, and I know firsthand we have cutting-edge curriculum based on all the latest scientific research as to how to educate and what to educate at what ages. So we have actually a K through 12 curriculum sitting beautifully polished on the shelf in the Department of Health. The issue comes down to the cost of really training the teachers that are responsible. And it also comes down to, I think, a mandate saying, yes, we have to make sure we separate out health education from phys ed, and that we say there must be so many minutes of health education per week, per class, to help move this needle. As I said, we're not testing for it other than through an anonymous survey. And so what we are testing in the public schools is whether they're making these academic benchmarks, but we're not testing anything around what their health education knowledge is. So I don't know what that cost would be. I know the curriculum's developed, and we need to get our teachers feeling comfortable about this subject matter.
Why aren't more schools providing contraceptives as part of medical visits, such as those programs at the Met and Woonsocket schools?
A lot of this has to do with legislation. The state of Rhode Island does not have legislation that specifically states it is okay or not okay to provide contraceptives during the medical home visit. So I think there's a lot of discomfort with many of the school boards that regulate the schools in your local community as to what the school nurse can or cannot do. I'm not as familiar with the Woonsocket school program. I have visited the Met school program, and they do have a full-time nurse practitioner there. And that, the way the Met school is set up is that is their medical home. All the students who attend the Met school use the clinic at the school as their medical home. So they have a very different kind of model than is often seen in other public school departments.
Is there a way that college campus and students can help to further education of these young adolescents? Is a Big Brother, Big Sister-like program an option?
There are two really great programs that I am aware of, and I spoke of them. One is called Youth's Pride, and one of them is called Youth in Action. And they are peer-to-peer programs that operate after school that have been incredibly effective in working with their own peers in helping to promote what I would say sexual health literacy. And so, yes, there is very much a place for college students to be supportive in those programs and to help grow those programs. It's one thing for someone like myself who's an adult to go in and talk with students, but they're mostly uncomfortable talking with me about these issues. Let's be honest, they're going to be much more comfortable talking about these intimate issues with someone closer to their own age. And so we do a great deal of training in these youth programs to make sure that the leaders in the youth programs have all the accurate medical information and also have access to their own support group, because sometimes some very difficult issues come up and they need support as well. And that would be a great place for college students to become involved in.
From the audience, isn't poverty the real problem and education just a Band-Aid?
I would say education is the real problem, and as a result of lack of education, we end up with poverty. I'm a real strong believer in the value of education, and I think when people are educated and have access to knowledge, they have the ability to make good life decisions and have the opportunity to move forward in their lives. But I think lack of education is pretty much a guarantee to a road of poverty.
Do you believe that another reason minorities carry on with their pregnancy because they do not have the funds for abortions?
I have no opinion or knowledge base on this. I don't have a good handle as to why teenagers choose to continue their pregnancies, other than to say I have the same sort of thought process that probably everybody else in this community has, and it probably has a certain level of prejudice in there. So I'm just going to let that one sit with all of you.
What do you predict will happen in the next 10 years in Rhode Island regarding unplanned or unwanted pregnancies?
Well, if Dr. Fine and I have my way, we're going to markedly diminish the unintended, unplanned pregnancies.
Okay. Can you suggest some ways to combat the underlying cultural values that lead to social injustices involved in women's health today?
I'm not sure I understand what they're trying to get at on that question, to be honest. Certainly we have cultural values that we live in a society where women still are not equal to men on many levels. And so it is something that as a woman I continuously work on and encourage other women to be proactive in our own right for our own causes. I think being involved is probably the most important thing. Getting involved with groups, getting involved in policies, getting involved in politics, getting involved in your community is probably the best way to stay informed and create a change and to start to change the culture. If we're not talking, it allows us to remain behind closed doors and not have the more difficult conversations. There probably is a role that all these iPads and iPhones and Skyping can play in helping to break down some of these barriers as we move forward.
What are the financial and or social benefits of paying healthcare providers to expand or initiate their discussions on sexual health and family planning? And what reforms are needed to adequately educate and reimburse providers to provide these key services?
Well, I think we know pretty clearly what the financial benefits are. We saw those figures of what it costs to have babies that are preterm or at risk. So it seems to me pretty easy to go forward and try and make sure that all of our healthcare providers are adequately trained in sexual health and family planning, reproductive services. The problem is we can't always get the students into the visits. In the state of Rhode Island, as I said, we had 40% of our students who never saw their primary care doctor the year before, nor did they have a medical home, a primary care doctor where they received their medical care, and that's discerning to me. I'm a strong believer that regardless if you're healthy or not, you need to see your doc every year, and your doc needs to be having certain conversations with you every year to ensure that all is going well for you. So I think going forward, again, it comes down to education. Getting the word out, having these conversations, and really encouraging our adolescents to go forward and self-advocate for themselves, giving them that power.
You address programs that would educate young women in contraception, but what about programs for the other half of the equation, the males?
I didn't mean to just single out women. I did try to say men needed to learn this material as well. But I think men have a very different dialogue to have than women with regards to health education, intimacy. So I would love to see some youth programs that are developed around males' responsibility. It takes two to tango, as I always say, and yet it's almost always the woman who ends up with the more than the lion's share of the burden in raising a child. So I would love to see some, maybe coming out of URI, some men's support groups and some men's groups to talk about the issues that the young men are facing today.
Why aren't most schools handing out condoms?
Somebody has to pay for the condoms. And I'll be really honest. It is embarrassing. The other day in researching for this talk, I went to CVS, and I shared this with the class this afternoon, and I couldn't find the condoms at CVS. And I was really, really embarrassed because I had to go and ask the clerk where the condoms are, and the clerk turned to me and said, "Oh, you're the First Lady of Rhode Island." And here I am going to buy condoms, so I can see how much they cost. And I learned they're kind of expensive. It's $1.50 a condom if you buy the economy box. And if you don't buy the economy box, they're about $2.50 a condom. So, I would love to see our universities passing them out, having a bowl in the cafeteria just there for everybody to take. But I think the real issue on that, one, is sensitivity. Not everybody's going to appreciate that, and I absolutely respect that. But certainly condoms should be available for free. I believe in that at some discrete place on campus that is comfortable for the majority of our students. But again, I think it comes down to a cost.
You said I could ask any question. So do you think that there should be a law regulating or prohibiting low-income families from having more children than they can adequately care for, or at least some form of guidelines?
Well, I don't believe in a law because this is the United States of America. But I'm also a realist, and I would hope that from a societal point of view, we could come and have discussions with people about how difficult it really is to raise a child and help them to understand what they're getting into, in hopes that maybe they'll say, maybe I need to wait a little bit longer so that I can actually financially afford this child. I can spiritually or emotionally support this child. I have the physical ability to support this child. Mrs. Clinton had it right. It takes a community to grow a family and to raise a family and raise a child. It is really hard work. It's wonderful work, but it's hard work. And so to raise healthy, active children, I think we need to do a better job of sharing how difficult it is. I get very frustrated when I see the teen moms all over the OK magazine and People magazine, and there's some reality TV shows which I have not watched, but they really glamorize the raising of children. And the bottom line is, at 2 o'clock in the morning, when you're sitting there sleep deprived for weeks on end, and your child has a fever of 102 and is throwing up all over you, it's really not very glamorous. And there are lots of those moments as you raise children that are very difficult and require at least two parents to get through the process, I think. And I have a fabulous husband who is always there for me. And I'll also say, thank God I had a great mom there as well as other support in the family to help raise the children. I just think it's immensely difficult to raise happy, healthy children.
Rhode Island doctors get reimbursed at lower rates than many other physicians. Does this lower rate affect primary care for young people? What is Rhode Island doing to create reimbursement?
Rhode Island doctors do get a lower rate for Rhode Island primary care doctors are reimbursed at a lower rate than other specialty physicians in the state of Rhode Island. I know that there has been a lot of discussion with Chris Kohler, who is our insurance commissioner, with Dr. Fine, with Blue Cross Blue Shield, and with United Healthcare and Tufts to try and change how the payment system goes forward. And I think under Obamacare, we're going to stop paying for fee-for-service, and we're going to start paying for outcome and healthy populations. And I think that will produce a significant change in how care is delivered in the state of Rhode Island as well as across the nation.
How much do you influence the governor to reinforce your efforts?
Sweetheart, would you like to answer that? Believe me, he hears it. Maybe some days it goes in one ear and out the other, but I promise you he hears it.
In Rhode Island today, what is the location of the, quote, poorest community in terms of its overall health care needs?
I don't know that for a fact, but I'm going to guess Central Falls probably remains one of our poorest communities in terms of their health care needs.
What do you think about single parenting household and gay parents?
Well, single parenting household, as we know, the statistics are not so great. And as I say, it's really hard to raise a child. I have nothing against any mother who wants to raise a child. I just say, do you really know what you're getting into? Because it is hard. And I do actually have several friends from high school, actually, who chose in their late 30s, early 40s to adopt a child because they were never married and very much wanted to be a parent. But I think you have to go into it with real thought process as to what you're doing and how you're going to raise a healthy child, because it's not easy. As to gay parents, I have absolutely no concerns about that. And as many of you know, I married for the first civil marriage for 2 gay people in the state of Rhode Island just in the past year and a half. So I'm a very strong supporter of gay parents and gay rights.
That's it.
Thank you very much.
Thank you.
First Lady Stephanie Chafee, for having this difficult conversation with us. And I'd also like to commend the audience for their questions. I thought they were excellent questions. So next week on Monday, please come. We were having Paul Farmer, the subject of the book Mountain Beyond Mountains. This will be on Monday the 19th at 7 p.m. And Mrs. Chafee mentioned a couple of times tonight Dr. Fine. He will be here the week after on the Tuesday. He is the Commissioner of Health for the State of Rhode Island. So he'll be our speaker in 2 weeks. So thank you very much for coming.